Before we go into talking about the Rasmussen paper, I'd like to take us back a few years to think about what the situation was for people with HIV and what was happening in terms of therapies in the 1990s. This was a time when we saw a whole variety of new, very effective treatments being developed, and it was discovered that you could put them together into what were called informally treatment cocktails at the time of 3 drugs that together really were very effective at suppressing the replication of the HIV virus. This was a so-called highly active antiretroviral therapy, or HAART. Now, early in the HAART era, there was beginning to be a number of reports from clinicians of a pattern of symptoms that patients under treatment were getting that involved a very thin legs, so they would lose the fat in their arms and their legs, and their faces would be very gaunt. But this wasn't HIV wasting disease because they would be fat in other places. Their midsections would be fat. They would often have thick necks and fat pads on their back, something that was called a buffalo hump. The first reports of this pointed out that the individuals who were developing this problem had been receiving one particular class of anti-HIV medicines, and the authors, without really knowing how it might happen, speculated that there could be a connection between the two. Now, these observations then got expanded. There were all sorts of disorders of energy metabolism in people who were getting these same early potent anti-HIV therapies. To understand why a drug that was effective against the virus might also have side effects for individuals, we have to understand that most drugs that are used to treat infections depend on what you might call a differential toxicity. That is, you identify some aspect of the infecting agent which you can disrupt, and that part of the agent's metabolism isn't shared with the host. And so you get a selective toxin that affects the agent. In the case of antiviral medications, generally these are related to the replication of the viral DNA, which is taken over by, or RNA, which is happens as a result of taking over the cell's metabolism. Well, antiviral agents are very difficult because so much of the viral reproduction simply uses the cell's metabolism. So it's not unusual to find antiviral agents which have some sort of spillover effect. It's not known exactly, but what it certainly is the case is that some of the medicines that are good against the human immunodeficiency virus also affect the mitochondria, which are the parts of the cells that are involved in energy metabolism. And this was thought possibly to be the link. Now, the problem in really studying this and isolating where this came from was that people with HIV themselves have higher rates of diabetes than other people. So it's related to immunodeficiency. It's also related to infection with hepatitis C and a whole variety of other things that are also not uncommon in patients with HIV. On top of that, the drugs that were being used were being given, as we said, in cocktails, so that it was hard to parse out the effect of one drug or another. And because the virus would develop resistance in a given person, the drugs that were being used would change over time, even with the HAART therapy. So we were stuck with a problem of increased risk and of drugs that we couldn't do without. Now, over time, new drugs in the same classes came in and appeared to have less of an impact on diabetes, on the occurrence of diabetes in HIV patients. So we're now at a state where that problem, which was very acute in the 1990s, seems to have diminished. What we're going to talk about for our paper is a some research in Denmark using a whole variety of national databases that helps pin down the timing of what happened, and also to look at other factors which might be related to the occurrence of HIV of diabetes in people with HIV under treatment.